Good morning, sir.
Good morning, sir. Good morning, madam. Am I audible, madam?
Good morning.
Yes, sir.
Chandra.
Good morning to all.
Good morning, Anuradha.
Yes, sir. Dr. Sai,
Ma'am, am I audible?
presentation. Yeah. Presentation, no, Petco.
Okay. Ma'am, screen share open kar, ma'am.
Yes.
Oh, okay.
Sir, start చేసేద్దాం సార్ 8.
Good morning to all. Today's presentation thromboelastography. Dr. Sai Srujan is presenting the tank. Is recently joined in Care Hospital. Dr. Sai, please start.
Yes, ma'am. Good morning, sirs and madams. Today I'm going to present on thromboelastography. Introduction. The coagulation cascade serves to stabilize the clot that has formed and further seal up the wound. The goal is to form fibrin mesh within the platelet aggregate to stabilize clot. The impaired hemostasis can contribute to intra and perioperative bleeding and is associated with increased morbidity and mortality. The conventional tests of coagulation monitoring are tests of coagulation, which include platelet number and function, coagulation clotting studies, PT, APTT, fibrinogen levels, and the test of fibrinolysis are degradation products like D-dimers. The test measures different aspects of clotting process, but do not provide complete picture. Even the platelet quantitative analysis is not provided and not the qualitative index. Coming to the coagulation cascade, after the tissue injury, the exposed collagen will start the intrinsic pathway, which activates factor 12A, which interactivates factor 11A, which interactivates factor 9A, which will activate factor 10A. Coming to the extrinsic pathway, the release of tissue factors will activate 7A, which will activate factor 10A. From factor 10A, it will form the common pathway. The factor 10A will activate prothrombin to thrombin, which will activate fibrinogen to fibrin, which will form a fibrin clot in presence of stabilizing factors. Coming to warfarin, the warfarin acts on factor 9A, 7A, and 10A. Factors like, the anticoagulants like heparin and enoxaparin will act on 10A and 2A. And dabigatran is a thrombin inhibitor, and dapagliflozin, edoxaban, and rivaroxaban will act on direct 10A inhibitors. The blood components used for abnormal coagulation is platelet concentrates, which can be single donor units, which is prepared from one donation, pooled units, which can be prepared from 4 to 6 donor units pooled into one pack to contain an adult dose, and platelet pheresis, which is collected by a cell separator device, which is equivalent to 3 to 10 single donations. The platelet concentrates are indicated in thrombocytopenia, platelet fraction defects, bone marrow suppression. Is not indicated in ITP, TTP, and DIC. Fresh frozen plasma contains normal plasma levels of stable clotting factors, albumin, and immunoglobulins. Factor 8A, factor 8 levels at least 70% of normal fresh plasma levels. The plasma separated from one whole blood contains within 6 hours of collection and then rapidly frozen to -25 degrees or colder. It's indicated in replacement of multiple coagulation factor deficiencies, like example liver diseases, warfarin overdose, and depletion of coagulation factors in patients, and receiving large number of volume transfusions in DIC and TTP. Cryoprecipitate contains half of the factor 8 and factor 3 and fibrinogen in the donated whole blood. It's prepared from fresh frozen plasma by collecting the precipitate formed during controlled thawing at +4 degrees centigrade and suspended in 10 to 20 ml plasma. It's indicated in von Willebrand factor deficiency, factor 8, and factor 13 deficiency. Coming to the differences between cryo and FFPs, the fibrinogen is present in both FFP and cryo, but in cryo it's a lesser number. In coagulation factors, FFP includes all factors, whereas cryo includes only factor 8, 13, and von Willebrand factor. Coming to TEC technology was originally described by Hatat in 1948 at University of Heidelberg School of Medicine. Thromboelastography is a viscoelastic assay that provides graphical evaluation of kinetics of all stages of clot formation that includes initiation, propagation, strength, and dissolution. This is the graphical representation of the TEC, that's a thromboelastography. Here we can see the PT and APTT will only indicate the initiation of the clot, which indicates by R time, and the progression is and stability are indicated only in the TEC. Coming to the monitoring dynamic changes of the hemostasis may be enabled in TEC. Distinction between surgical causes of bleeding and coagulopathy. Diagnosis of specific type of coagulopathic impairment is seen in TEC. And guidance of choice in hemostatic treatment is helpful for it. TEC is helpful in guidance of choice. This provides visual assessment of clot formation and subsequent lysis under low shear conditions, similar to those present in vena cava and well below those seen in venules, large veins, and arterial system. Coming to the technology of TEC, there will be a heated cup, which is heated at 37 degrees centigrade, which will be oscillating for 4 degrees to 45 minutes in 5 seconds, in which the pin is suspended from torsion wire into blood. The development of fibrin strengths couple both the motion to the cup. The coupling is directly proportional to clot strength. Torsion in wire is detected by EM transducer. This electric signal is amplified to create a TEC trace. TEC6 is a newer machine which is no longer uses a pin and cup technology. It uses resonance where blood is exposed to a fixed vibration frequency range. The detector measures the vertical motion of the blood meniscus under LED illumination and transforms the movement into tracing of clot dynamics. With pre-prepared cartilages, there is no longer any pipetting required. The TEC6 employs a secreted multi-channel cartridges containing 4 channels that perform different assays. This is the differences between TEC and ROTAM, which is rotational thromboelastometry. Here the pipetting is done manually in TEC. In ROTAM, it is automated. In cup motion, it's moving in TEC, whereas it's fixed in ROTAM. Pin motion is fixed in TEC, and whereas moving in ROTAM. Angle of rotation is 4 degrees 45 minutes for 5 seconds in TEC, and it's 4 degrees 75 minutes for 6 seconds in ROTAM. Detection is by pin transduction, whereas it's impedance of rotation in ROTAM. Coming to different parts of thromboelastography, first is the R time, is the time until initiation of fibrin formation taken as a period of 2 mm amplitude and the tracing. That's from here to here. This is the R time. It indicates concentration of soluble clotting factors in the plasma. Its normal is 4 to 8 minutes, which is colon activated plasma. The prolonged R time may be due to anticoagulants, factor deficiencies, and severe hyperfibrinogenemia, and is reduced in hypercoagulable conditions. K time, that's a time period from amplitude of tracing to increase of 2 to 20 mm. That's here to here. Measurement of clot kinetics, normally it's 1 to 4 minutes, it's colon activated. Increase in K time by anticoagulants, hyperfibrinogenemia, and thrombocytopenia. Here, the R time doesn't contain any thrombocytopenia. That indicates that platelet functions are indicated only in indicated in K time and further measures. And there will be decrease in the increased fibrinogen and increased platelet function. Alpha angle is the angle between the tangent of tracing at 2 mm and amplitude and the horizontal midline. And this is the tangent, and is rapid rapidity of the fibrin buildup and cross-linking. Its normally angle is 47 to 74 degrees. The increase in alpha angle is by increased fibrinogen levels, increased platelet functions, and decreased alpha angle is by anticoagulants, hypofibrinogenemia, and thrombocytopenia. Maximum amplitude is the greatest vertical width achieved by tracing, reflecting maximum clot strength. And this is the maximum amplitude and indicates the clot strength. The number and function of the platelets and fibrinogen concentration. Its normal is 55 to 73 mm coagulant activated. Increased maximum amplitude is by hypercoagulable states and thrombocytosis, and decreased by thrombocytopenia, platelet blockers, fibrinolysis, and factor deficiencies. Clot lysis 30 and clot lysis 60 is the percent reduction of an amplitude at 30 minutes and 60 minutes after maximum amplitude respectively. It indicates clot stability and fibrinolysis. Its normal is 7.5%. It's the clot lysis at 30 minutes and the clot lysis at 60 minutes. Qualitative analysis, the clot formation depends on clotting factors, which is indicated by R time and K time. The clot kinetics on clotting factors and platelets, which is indicated by R time, K time, and maximum amplitude. The clot strength and stability depends on platelets and fibrinogen, which is indicated by maximum amplitude. The clot resolution on fibrinolysis, which is indicated when clot lysis in CL30 and CL60. TEG uses several samples run in parallel with a variance of activators and inhibitors, allows a process of clot initiation, propagation, stabilization, and resolution to be evaluated separately. Refinements in TEG, which includes activators and inhibitors. Covalin is the activator, which is results similar to PTT. In rapid TEG, a reagent contains covalin and tissue factors, which is analogous to ACT. In HTEG, it contains a lyophilized heparinase, which neutralizes unfractionated heparin. The functional fibrinogen is a reagent contains tissue factors and abeximab, which is a platelet receptor inhibitor that blocks the platelet contribution to clot formation. This allows quantitative analysis of fibrinogen contribution to clot strength independent of platelets. Platelet mapping utilizes heparinized blood mixed with activator F, which allows determination of platelet activation response to these antagonists in the absence of thrombin. This is the TEG6 indicators, which contains citrated covalin, citrated rapid TEG, and citrated covalin heparinase, and this is separated functional fibrinogen. These are different TEG graphics which we get in TEG6. These is the values we got during the anhepatic stage of the liver transplantation. Here we can see the K values are increased and maximum alpha angle is decreased with which indicates either fibrinogen or platelets are deficient. With saturated functional fibrinogen, which is very less, indicates the fibrinogen is the main in the deficiency. So we have transfusion of FFPs during the anhepatic stage. In this case, these are the different types of TEG which we get in abnormalities. This is the normal TEG, which has R, K, and MA angle, which are all normal. This is the TEG graph which we get during the anticoagulants or hemophilia in factor deficiencies, where R and K are prolonged and maximum amplitude and angle are decreased. And this is TEG which we get in platelet blockers, where R is approximately normal, K is a bit prolonged, and MA is decreased. This is the TEG which we get in fibrinolysis, in which the R is again normal and MA is continuously decreasing with the lysis time which is less than 75% and lysis 60 is less than 15%. In hypercoagulable states, where the R and K are decreased and maximum amplitude and angle are increased. In TEG stage 1, it's a hypercoagulable state, so with there will be a decrease in R time and increase in MA. In stage 2 is a hypercoagulable state, and we get this type of graph. This is a TEG-based transfusion algorithm where R is more than 14 and less than 21 minutes, where there is a decrease in clotting factors and the DERP is 1 FFP. If the R is more than 21 and less than 28 minutes, there is a very much further decrease in clotting factors, there will indicate 2 FFPs. When R is more than 28 minutes, there is decrease in clotting factors where 4 FFPs are indicated. With maximum amplitude less than 48 mm, there is decrease in platelet number or function, and so 1 pooled platelets are indicated. When MA is less than 40 mm, there is further decrease in platelet numbers, where 2 pooled platelets are indicated. With lysis 30 more than 7.5%, there is increased lysis where antifibrinolytics like tranexamic acid are indicated. The strengths of TEG are it provides a rapid assessment of overall coagulation status and parameters are used to guide the administration of specific blood components. TEG-based transfusion algorithms have been shown to reduce rates of transfusion of blood components and reduce rates of surgical reexploration. It's been shown to be of benefit in detecting a hypercoagulable state in postoperative patient. The best predictor parameter is increased maximum amplitude. The TEG coagulant cartridges are executively sensitive to residual heparin, which may be useful in detection of inadequate heparin reversal or heparin rebound. The limitations of TEG are it cannot be reflect the contribution of endothelium to coagulation. The preoperative TEG is a poor indicator of postoperative bleeding. Will not reflect the effects of hypothermia. The TEG methodology is yet to be standardized in terms of sample collection and processing, activators use, and other modifications, making it difficult to compare between institutions. The differences between TEG versus conventional studies are the conventional studies are static tests, whereas TEG is a dynamic test. The conventional test varies various parts of coagulation cascade, but in not resolution. In whereas TEG tests global function assessment of coagulation and fibrinolysis. Conventional test is difficult to assess platelet function, whereas TEG gives assessment of platelet function. Conventional test plasma tests may not be accurate reflection of what actually happens in patient, whereas cellular surface light are used in TEG which to monitor coagulation. Conventional test takes time to complete and delays treatment, whereas TEG is a rapid test which gives a rapid monitoring of intervention and rapid association. Anesthesiologist specialty has taken a leading role in evaluating TEG as a point of care monitoring of hemostasis in several clinical settings. Specialists feel that near-site hemostasis monitoring could significantly improve clinical discussion, making it patient undergoing surgeries like cardiac transplant, obstetrics, and trauma resuscitation. In liver transplantation, each of the 3 phases of orthotragic hepatic transplantation has associated with metabolic, hemorrhagic, and other derangements that complicate the pre-existing coagulopathy present in these patients. Transfusion requirements are highly variable, but sudden massive blood loss occurs in conjunction with hyperfibrinolysis, coagulation factor, and inhibit deficiency, and thrombocytopenia. With prompt and effective treatment, the complicated clinical coagulopathies can result in dramatic hemorrhagic consequences. This is a study done by Kung et al. Demonstrated that use of TEG for monitoring hemostasis during liver transplantation decreases blood transfusion requirements. TEG is used in cardiovascular surgeries also, because heparinase assays are very useful in patients on cardiopulmonary bypass for early assessment of clot kinetics and strength in the presence of unfractionated heparin. The concentration of unfractionated heparin present during cardiopulmonary bypass will yield a flat line ROTAM and TEG trace without the addition of heparinase to sample. This is a study done at Tuman et al. Demonstrated that heparinase treated whole blood may be used to measure the TEG during cardiopulmonary bypass to facilitate prompt treatment of significant coagulopathy immediately after heparin reversal. The study is evaluation of coagulation during cardiopulmonary bypass with a heparinase modified thromboelastographic assay. In obstetric anesthesia, also it's used. The physiology of pregnancy per se is a hypercoagulable state that prepares a parturient for hemorrhage of the childbirth. Several factors involved in coagulation cascades and platelet reactivity increases during pregnancy, while naturally occurring anticoagulant decrease. TEG is useful in conditions like preeclampsia and PPH. In trauma anesthesia, the acute trauma coagulopathy characterized by systemic anticoagulation and hyperfibrinolysis believed secondary to endothelial injury and activation of protein C may progress to trauma-induced coagulopathy following ongoing blood loss, fluid replacement, and development hypothermia, tissue estesis, and hypoperfusion, which is a triad of death. In a study of Kofferman et al., only the injury severity score and the TEG were predictive of the early transfusion. Usefulness of the thromboelastography is as an assessment of trauma patient coagulation. These are other studies which was done by Diaz et al., in which cartridge-based thromboelastography can be used to monitor and quantify the activity of unfractionated and low molecular weight heparins. In this study, the study suggests that the TEG6 system can be used effectively to monitor anticoagulation and hemostasis within the therapeutic ranges for both unfractionated heparin and low molecular weight heparin and can accurately classify 78 to 92% of blood samples according to clinically relevant levels of heparin. This is another study done by Nelson et al. The study is the effect of coagulation factors deficiency on plasma coagulation kinetics determined via thromboelastography, clinical roles of fibrinogen and factor 2, 7, 10, and 12. The fundamental finding of this study is that the coagulation factor deficiency affects TEC parameters in both the factor dependent activation dependent fashion, and utilizing both SILET and tissue factor activation improves the diagnostic power of the TEC. Based on such data, more targeted administration of blood products could potentially help improve perioperative hemostatic outcomes. This is the other study where the functional fibrinogen done by Harar et al. The functional fibrinogen assay indicates that fibrinogen is critical in correcting abnormal clot strength following trauma. The functional fibrinogen can perform rapidly with TEC and correlates well with its standards with Von Clot fibrinogen assay. This Von Clot fibrinogen assay is a real-time assay where the fibrinogen clot strength can be assessed. The both fibrinogen and platelet contribution of the clot strength can be derived from functional fibrinogen. Moreover, the functional fibrinogen has a stronger correlation to clot strength, and increased levels were directly associated with increased percent of contribution of the clot strength. Thank you, sir.
Very nice presentation, Sai Sujan.
Thank you, sir.
Very informative. And I missed maybe one slide. What is the role of TEG in dengue patients?
So dengue patients also have platelet and coagulation abnormalities. So dengue patients can also be used for TEC, sir, where we can assess the coagulation factors are deficient or platelet factors, platelets can be deficient. We can assess, sir, or whether which coagulation factors can be FFPs can be given and platelets can be given can be assessed.
No, because my question is normally platelets, the number may be normal, but the work may not be done.
Yes, sir, qualitative.
So
Yes,
how do you assess that in TEG?
the kinetics will be different with the
Maybe amplitude may be reduced, sir.
But amplitude reduced because of the non-clotting. But how do you decide it's a platelet working or not working if the number is there or not there?
Maybe both the K time and the maximum amplitude can be assessed, sir, where the K time angle, alpha angle will be increased and maximum amplitude will be decreased, sir. I guess so, sir. I don't know in person.
What I'm trying to ask you is that Dr. Anuradha and Sai Sujan, normally the TEG is going to be for an action of clotting factor. It doesn't have any role to identify the working condition of the platelets. It's a different mechanism, I believe. I just want to confirm with you people, yes or no?
Yes, sir. Actually, the platelets function can be assessed with the platelet function assist, sir. A separate monitoring device can be used.
Yeah, around 4 years back,
Platelet
BMC,
mapping.
but still they didn't continue that. Yeah.
Yes.
Very nice presentation, open for discussion. There's a lot of things in TEG because in Vizag, only Anuradha is having TEG mission. Nobody is having TEG mission. I mean, Care Hospital is having. So I request Anuradha to make it active and make available for everybody whenever they want how to really approach. Like, for example, we used to do ABG in Care 2 from the KGH. A lot of people used to come and get it done. So the other proposal, I request including the intensivist and anesthesiologist because 24 hours availability of intensivist in Care Hospital may be useful for the society as well as to the people in care. But in CT, in cash patients, you may use it because of costness. So what are the times, Sai Sujan, you use TEG in CT?
While under the cardio, I mean, in CPB, there may be a few cases may land in cysts, sir, where we can see for heparinase action or the deficiency in coagulation factors. Sir?
After what duration? Every patient on CPB you see or after some duration you do?
After some duration, sir, actually.
Thank you.
Thank you, sir.
Thank you, sir.
The tech machine is available in Care Hospital. So that machine is keeping in CT ICU. If anyone want to take for any problems, so directly please contact with me only. So directly we can do, because that cartridge cost 8,000. So
Anuradha, it is not for the cost. It is availability, because 24/7 you cannot be available, no?
no, it is available, sir. So only issue is only technician will do. Other people can do, no, that cartridge will damage. So that cost also very high, no. So only biomedical people only do that technician is using. If anyone sending, please directly contact with me. I can directly contact to biomedical and do as early as possible. And one thing is no printed matter, so that's why I can send by WhatsApp that pic.
So there is two things here for all the people. There is a, what is that machine to do the David is doing in a Pinnacle Hospital for ABG. What is that? Coaximetry. Am I right? Somebody from Pinnacle is there? Hello? Srikanth?
Sir.
మీ దగ్గర కోఆక్సిమెట్రీ ఉందా?
లేదు సార్.
సో నాకు తెలిసి పెనకిల్లో ఉంది అనుకుంటున్నా.
ఓకే, పెనాకిల్ నుంచి ఎవరు జాయిన్ అవ్వట్లేదు డేవిడ్ సార్.
నేను చేయించినట్టు గుర్తు. Okay, what I'm telling is, because of the usefulness we can use, because all coaximetry cases, when we want, we can send it to and whenever we want TEG, we can send it to care.
Sir, good morning, sir. This is Omkar.
Omkar, మీ దగ్గర మర్చిపోయాను, you are right person to come. Do you have any mechanism to see in Vijaya Medical Center what the platelet function is?
I will once talk to Sriman sir, then I can, I think, let you know. As of now, I don't think so, sir. Only they are giving the numbers, that's all. Functional activity specifically, they are not at all giving any specific mention or report, sir. I'll talk with Suman sir and Madan sir again. So even my question was the same thing, sir, because many people, especially in CAB, were posted for CABGs and all, they will be on long-standing antiplatelets like Ecosprin or Clopilate. And what could be the, how can we assess the platelet function, not only for CABG or else any other case posted for any other surgery? So will this be helpful? And my next question is, at what point of time should I think of elastography for a patient, in OT or else in ICU?
Yeah, very nice question. The first question, what I'm thinking, I don't know, I may be wrong, is because the lifespan of the platelet count is less. So that's why we give maximum of 72 hours to 96 hours is the belief. So we stop for medication for 4 days because of the half-life of the medication as well as the lifespan of the platelets. These are the two reasons. And the second question answer is when to do, let somebody else speak, seniors, then we, if at all anything is there, we can add. Thank you. Maybe Rani madam is not speaking. Any others? And more than that, routine working people, Chaitanya, Chandana, all these people, Naveen, who are regularly working in OT. Or is Monanga Srinivas is there in ICU, or David or somebody from ICU? What are the cases we should do TEG so that we'll know? Thank you.
Any male students can also talk.
Hello.
Madam, good morning. Audible, madam.
Morning. I think platelet blockers or thrombocytopenia, I think they both can give the similar kind of picture in TEG, whether it's a platelet blockers like antiplatelets or thrombocytopenia. It doesn't differentiate which one, but practical purposes, effectiveness of platelets is not there. That also means the same as thrombocytopenia for TEG machine. So I think the TEG picture is, as Anuradha and Srujan was saying, it's a little bit different from normal TEG, normal coagulation person's TEG. So I think the R time and K time, they are like slightly prolonged, and overall that amplitude is smaller in thrombocytopenia or antiplatelet patients. So that way we can compare with the normal TEG and make out it's because of this antiplatelets or thrombocytopenia. I'm sure that can be differentiated from normal person. So that's also one indication where in trauma patients or thrombocytopenia, you can make out whether it's just coagulation factor deficiency or coagulation factor deficiency. The initial line, what's that? R time, that's very prolonged. And in thrombocytopenia, R time is not that prolonged. Little bit prolonged, and K time is little prolonged, and the amplitude is small. That's what I understood. Thank you.
Chaitanya Pantulo inka health baleda?
Sir, she is a case. So in thrombocytopenia and platelet dysfunction means R time is normal and K time is increased and alpha angle normal, ma'am, and amplitude is reduced.
Ade kada chepparu.
Yes, that only, ma'am. So that time you can give platelets.
So one more thing, normally when we send a platelet count in the lab, so the TEG, there is a clusters formation. So the counting of the machine counting is different, manual counting is different. Whenever the machine counting and manual counting is different for a lakhs of cells, so it is not a problem. The problem comes, there is no clinical picture of bleeding. There is no clinical picture of any problem, but still your count is so low, you are afraid. You want to give transfuse SDP or platelets concentrates. So what happens is here, the platelets, when you are asking pathologists to see the platelets in the cell smear, if they see a lot of giant cells, because giant cells is the thing which is a precursor of platelets. So that means even the platelet count is low, not to worry, because it's in recovery phase. And he is going to improve, he or she is going to improve. So you can be more confident that you can only ask them to put in the blood bank only storage. Don't bring it here and waste the products. Because the problem is, once you give that platelet to the patient from the outside, because of the foreign body, the immunity comes down and the prolongation of regeneration of platelets delayed in dengue patients. So there are two important points here. Is that how early to be given platelet transfusion is one important aspect. At the same time, how many days you should really wait for it, because it only depends on, if you remember, for a dengue patients, because my worry is that a lot of patients, even in Vijayawada now, I'm getting information that so many people are dying because of dengue. So just because we don't do every 8th hourly hematocrit, and we don't do every 12th hourly platelet count, and we don't do intermittent, particularly myocarditis in markers like troponin and proBNP and ferritin. Ferritin is not actually myocardial, but still what they look into the damage of the cells, iron and hemoglobin coming down. So these are the things where they have to really look for before they convert from the normal case to the serious case. So that identification is really, really tough and easy as well if you closely monitor very intermittently. So this is what is my question. Particularly TEG is not helping in these type of conditions. As I said, it doesn't differentiate between the number of platelets. It doesn't differentiate because of the medication is bleeding is more. So intraoperatively, you don't know, maybe because of medication, what you are giving, heparin or what you are giving, effect, how much proagulant can be given, those kind of things is useful. And in ICU, it's a very tough job because you need to have, definitely it helps us. It helps us in polytrauma. It helps us, as he has given a lot of papers. Sai Sujan has given very nice, elaborative and good supportive documentation of studies, which one is indicated and all. And nicely explained, nicely given a talk on importance of it. But in ICU, when you are giving TEG monitoring, that is really tricky because you have to look into the pharmacological issues as well as the clinical issues. So thank you very much. I think I've taken a long time here. Sorry for that.
Hello, good morning. What is the role of tranexamic acid when a patient is bleeding, post-COVID patient on oral apixaban?
What is the mechanism of tranexamic acid, sir? Somebody? Sir, Raman Prasad, what is actually mechanism of
microvascular bleeding?
Particularly because it's used in gynecological procedures and obstetric cases. So it actually, how it works, sir? Andukani adigaanu sir ante. Because you have a lot of concentrate, you have vitamin K and vitamin factor 7, and you have a tranexamic acid, and you have a protamine, and these all the things are different to prevent bleeding. So which drug to be given where is a question here. That's what I understand. So you please, sir, Raman Prasad, sir, please carry on, sir.
Tranexamic acid has
Plasminogen inhibitors.
Tranexamic acid has no role in patient with apixaban because apixaban acts on the factor 9 common pathway. So FFP is better to give.
Tranexamic acid plasminogen inhibitors, as Chaitanya was mentioning. It actually, I think it binds to some amino acid on plasmin and displaces itself. Plasminogen inhibitor. Fibrinogenesis కూడా inhibit చేస్తుంది.
ఎక్కడ సార్ ముసలోళ్ళు వైపు కదా అన్ని గుర్తుపెట్టుకోలేకపోతున్నాం.
నాకు కూడా అందుకే సగమే గుర్తుంది సార్, చైతన్య అన్న తర్వాత గుర్తొచ్చింది.
But as Raman Prasad sir said very clearly, the mechanism of action is important because that's what I'm telling you. There's a lot of, even like, antihypertensives. You give calcium channel blockers, you give beta blockers. It depends on where you are getting the reason for the hypertension. Like that here, the bleeding is, as you said, TEG is going to really help us, but at the same time, it doesn't help us because of what patient is getting bleeding. So unless you correct that as a mechanism of action is more crucial and important. ఏంటంటే అది ఎవరు స్టూడెంట్సే లేరా క్వశ్చన్స్ అడిగేవాళ్ళు?
సార్ అందరు కన్సల్టెంట్స్.
ఓన్లీ అట్లీస్ట్ స్టూడెంట్స్ ఫ్రెష్ నాలెడ్జ్ ఉంటుంది, అది చెప్పినా చాలు కదా.
సార్ వెంకట హరీష్ మేము స్టూడెంట్.
Anything else, Anuradha?
Okay, sir. Dr. Thank you so much. Thank you, Dr. Sai.
Thank you.
Sir, can I close?
Yeah, Srikanth.
Please post the PPT in group.
Yes, sir.
Srikanth, can we close?
Dr.
yes, sir.
Srikanth?
మేడం నా దగ్గర ఉంది మేడం, నేను పోస్ట్ పంపిస్తాను.
Okay.
Susan has sent me.
Yes.
Okay, madam. Next week, my state conference topic, multimodal analysis. Next week, I will be taking that class. Sir, Mohan sir, Rani madam, మీరు కూడా అడిగారు. Next week
ఏంటి మళ్ళీ చెప్పండి శ్రీకాంత్.
సార్ నెక్స్ట్ వీక్ నేను అదే మొన్న స్టేట్ కాన్ఫరెన్స్ లో ప్రెజెంట్ చేసిన టాపిక్ చేస్తున్నాను సార్, మల్టీమోడల్ అనాలిసిస్. అదే మేడం మీ టాక్ కూడా చేద్దాం ఒక క్లాస్ అన్నారు కదా రాణి మేడం. నెక్స్ట్ వీక్
డెలీరియం చెప్పాను కదా. కోవిడ్ కేసా? కోవిడ్ బోర్ కొట్టదా జనాలకి? కోవిడ్ 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 అని తప్పు కదా.
ఓకే సార్, అయితే నాది అయిన తర్వాత ఇంకా ఓంకార్ నెక్స్ట్ క్లాస్. ఓకే సార్, నెక్స్ట్ వీక్ మల్టీమోడల్ అనాలిసిస్ సార్, పెరి ఆపరేటివ్ అనాలిసిస్.
థ్యాంక్ యూ.
ఓకే సార్, థ్యాంక్ యూ మ్యామ్. Susan, nice presentation.
Thank you, sir.
Nice
Thank you.
presentation.
Thank you to all.
Thank you.
Thank you, sir.